must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hey everybody, welcome to another episode of the Healthcare Education Transformation Podcast. I am one of your hosts, and my name is Brandon Powen, and of course I'm joined by my fellow co-host, Stephanie Wyrock. And today we have a very special guest on the show to talk about the APTA's clinical instructor programs, as today I'm thrilled to re-welcome onto the show Dr. Laurie Kontney. Now, if you're not aware, she was actually present on a prior episode that we did discussing the Educational Leadership Partnership, which was back a couple months ago. So if you haven't heard about that, check it out. It's down in the show notes below, as that's a great episode that featured three very prominent and very well-respected people within ELP. And it was definitely a very insightful episode, so I definitely recommend you listen to that. But to give a little context on who Laurie is, apart from that, she is the Director of Clinical Education and Clinical Professor at Marquette University in Milwaukee, Wisconsin. And she is also a trainer for the APTA Level 1 and 2 Credentialed Clinical Instructor programs, in which the APTA's program will be the topic of discussion today. So Laurie, thanks again for hopping on and for all that you do. I know that there's been a lot you've been involved in, and I'm sure that free time here and there is not easy to come by. But I get that some listeners also don't know a little bit more about you. Would you mind giving us a little bit more background into kind of your story and how it's kind of led you to where you are today?
Sure. It's interesting. I'm a first-generation college student, so that's an interesting fact for myself. And as a student, I sort of found a mentor without even knowing that's what I was doing that really helped and encouraged me as a new grad. She invited me to join. She saw my passion for teaching and said, you're going to be a good clinical instructor someday, so I want you to come and join our consortium at the time for clinical education that we're going to start and be a part of that. And then kind of pushed me outside my comfort zone. And before I knew it, I was not only a CI, but a site coordinator within a year of graduation. But I loved it. And I ended up going on and obtaining my master's and focusing my thesis work on productivity and clinical education. One of our local programs noticed that. And because I'd been active in our ClinEd consortium, was doing research in clinical education, invited me to interview for the position for the Director of Clinical Education at Marquette University. So I am now in my 26th year. It's a long time. I always like to chuckle and say I started at age 12, but I didn't. But so I've been involved in clinical education as a clinical instructor. I probably took over 100 students, PTs, PTAs, combos of PT, PTAs, and have tried various models. And I've kind of carried my passion for patient care into my mentoring of students. And I start from day one training my students to be clinical instructors by helping them understand the importance of assessment and feedback and self-reflection and professional growth. So so it's been a journey. I continue to change and evolve as needed to meet the needs of the clinic, but that's sort of where I started and where I am now.
I know that we had chatted in the past, Laurie, with Zohar Kapsi and Roger Hare regarding the Educational Leadership Partnership, or ELP, on a previous episode that Brandon kind of talked about earlier. And before we dive into talking about the Credentialed Clinical Instructor Program, have there been any big changes or updates to what ELP has done or learned since we last chatted?
Yeah, in fact, there was just a communication that went out to all the different partner groups with updates and what we've been up to. It's amazing to me what we've accomplished in a short amount of time. And we have a master plan. And really what we're trying to look at is we're trying to integrate the aspects of educational research, outcomes, essential resources, clinical partnerships between academic and clinical communities. And embedded within all of that is the clinical education and where and how clinical education occurs, not only throughout the curriculum, but then beyond, and that's both for PT and PTA. So right now we've held our strategy work group focusing on educational research because we all know that we need the evidence to support what we're doing and how important that is. So we are in the process of embedding educational research within all those different strategy groups. We completed a clinical education strategy work group meeting in the fall, and we will now be doing an outcomes one for outcomes in education in the spring, and then we're looking at essential research sources in the fall, and then partnerships. So essentially, we're doing a lot. We've formed a student debt task force. We are adding a physical therapist assistant rep, along with our other community and private practice and healthcare systems reps. So we've got a wide, audience of stakeholders that have their input. And again, to me, it's amazing how it's grown in just the few years that we've been together as a group. And so as it's relevant, especially to this presentation, is we really are looking at clinical education, how important it is, and what is the best way to administrate that and to get more evidence about what works and what's best practices in such an important key component of our curriculums.
Yeah, no, and it's been really interesting, like you had kind of said, what all the amount of amazing work that the ELP has been able to achieve. And one thing I might also recommend to listeners, if they're listening and they're perhaps not aware of this, is check it out on the website. But also, I would also check out the annual report that the ELP put out. And actually, they did it not too long ago for 2018. Mm-hmm. So that gives a really good summary of kind of what they've been up to, what they've been doing, and kind of some future things that they're going to do. So that's another good thing if you want to check that out. Laurie, I couldn't help but notice when doing a little bit more background research that you were actually involved with Dreamcatchers, which is an interdisciplinary think tank for ethics and rehabilitation. Now, I'm just kind of curious because it's something I hadn't heard about before. Would you mind expanding on this specifically, like how this group works and what you've really learned from being a part of this group?
Well, I have to say I was very fortunate, honored, and humbled to have been asked to participate because some of the founders of that group include Ruth Portillo, Dolly Swisher, Carol Davis, and some pretty, at the expense of missing out on people, I don't want to do that, but some pretty big hitters, both from physical therapy, occupational therapy, speech language path. But it's a group that really came together wanting to focus on how do we not look at ethics as just a topic over here that we need to talk about, but I always say, and I don't, just from hanging out with people that love ethics, and is really you can't make a patient-centered care decision without a moral component. So in essence, ethics is embedded within every decision that we make that's centered around our patients and best practices. So this group, although we haven't met formally in a while, the goal was to integrate ethics as part of everything that we do and not just a single topic that gets talked about in a class, but also research in that area as well as like programming at various different national conferences, regional conferences, and we've essentially accomplished that task. There's always work to be done, but if you look at the work that's being done on clinical reasoning and the importance of thinking about our actions and its impact on our patients and maintaining our integrity within our health professions and not letting someone else dictate what we do. I mean, all of that is ethics. So having been honored to be a part of that group, now we're seeing we have groups forming on professionalism, interprofessional. So I really think like it was a starting point for a lot of really good things that are happening within our profession and that we're collaborating with others. But I got interested because I just have always loved ethics. I've served on our licensing board. I actually chaired our licensing board in the state of Wisconsin for 2 years. So I'm really into the legal ethical aspects of patient care and how it has to be part of every decision that we make. So for me, it's a passion. I focused my doctoral work and took extra coursework in ethics because I really feel that's so critical for us to understand. And any of my students who might listen to this podcast will all have a smile on their face because they know how I do ethics discussion boards and how I really focus on the ethical aspect of care and best practices. In fact, I just talked about it in class yesterday. So really think it's important, and I've been blessed to have opportunities to have great mentors, and that we actually have a profession that values it so much that they form organizations or groups like the Dreamcatchers.
I think that you make a really good point, Laurie, about mentorship. And, one of the things that I think is most important about being a clinical instructor is being a mentor for the student that is working with you. So the CCIP Level 2 course is something that has recently been implemented. Why was that Level 2 class formed?
Great question. Initially it was called the Advanced Clinical Instructor Workshop, where we just took more advanced content area. However, what we really started to look at was, think about any college course you took. Any college course you took, you had a syllabus. And in your syllabus, it gave you information about what you were going to do, how you were going to be assessed, what teaching strategies would be used, when you needed to know the information, and what your end goal was by the end of the course. But then we throw students out into clinical education, and basically it's like, right, well, depending on what you do, you do. And they're even though we give them our syllabus, what the students have had, where they should be, there's not a whole lot of structure. And the Level 2, I think, is quite amazing. I just taught it a couple of weeks ago. It actually looks at structuring your clinical education process around a curriculum, so that if you're going to put structure in the academic setting, why not have some structure in the clinical setting? And what I really like about it is it looks at, who are you as a clinical site, and what do you do? What's important? What is it that you do with your patients that's really important that a student needs to get out of this experience? Not only as in skill set, but like, what is your company or clinic site? What do you value? What is important to you? What's your reputation? What is your brand? And it looks at the ability to then, with the end in mind, develop learning experiences for your students in advance to make sure that they get those experiences, that they leave with that brand or that value. And especially what I see most critical about it is we all know that students are going to struggle in certain areas, and it's not because they're not good students. They just, there's just some skills and tasks that are harder than others. And rather than wait for that to happen, why not have learning activities and goals and strategies and resources set ahead of time that you can use to help facilitate students through those areas? So the Level 2 course really looks at building a clinical curriculum that's personalized to your clinical setting, to the types of patients that you see, and the types of challenges that students might have, and it gives you the opportunity to adapt that for students at an earlier level of clinical learning versus later level. And how do you help students that are progressing at different rates throughout those different skill sets? So it really is a great way of being proactive in your clinical education. And I think by virtue of doing that, it makes you a more efficient clinical instructor. And I think it helps with some of the concerns around productivity and students taking a lot of time, because you're not waiting for that teachable moment, which is great, but you have planned learning. So that's what kind of spurred the development of it. And that's what I think is the most important part about it, is you're beginning with the end in mind and building a curriculum around that based on what that school expects and what that student needs to achieve.
Yeah, no, that makes perfect sense, Laurie. And something I want to dive back into just a little bit, because I recognize that there might be a lot of clinicians that are also listening who perhaps are not certified or have not gone through either the level 1 or the level 2. So of course, having to go through level 1 first, kind of being that requirement initially. But if we could, because I know that those people might be listening, could we dive into a little bit about the level 1? Because I know you had talked about the level 2, so I don't want to be redundant here. But what's kind of the overall structure and layout for the level 1 course?
Excellent question. I think if I were going to boil it down to the meat and potatoes, and then I'll kind of give you specifics, the level 1 course really looks at paralleling what you do as a clinician with what you're going to do as a clinical instructor. So when I see a patient, I first have to evaluate and find out what their problems are. And once I find out what their problems are, I want to know what their goals are. And I mesh their problems with their goals to come up with a treatment plan. And then I create interventions that are going to address those deficits so that I can then work towards resolving those deficits, which is my long-term plan. And I'm constantly reassessing every time I see that patient. Well, that's what we do with students. We get a student. Not every student starts at the same point. Not every student has the same background or experience. Not every CI has the same background or experience. So first thing we have to do is figure out what are the expectations for this clinical rotation? Where is my student at? And then based on that, I look at what does this student need? I create learning opportunities. I assess how that student's doing. I continue to progress them. So the level 1 course looks at, first off, what do you need as a clinical instructor? What characteristics or attributes? And again, comparing that to what you would actually just do as a clinician. And then it looks at what is the student's readiness to learn? How do you know? How do you facilitate that? It looks at what resources you have within your own clinical learning environment, both from a human perspective as well as like equipment and opportunities and experiences. And then it looks at teaching strategies, in particular, the value of assessment, feedback, questioning. And then it also delves into how do you help manage that student who's either struggling to be successful, and how do you challenge that student that's excelling? I mean, the worst thing I think you could do for a student is give them a caseload and a blessing. I mean, you really need to continue to challenge that student and to work to make them even better. I mean, our goal is, we want to be excellent clinicians. Why not model that for our students and look for excellence in clinical education? And then finally, they also look at the legal, like why it's important to create your paperwork, and just how to deal with students with disabilities, how to supervise appropriately. So that's the level 1. A lot of stuff, really just trying to get that clinical instructor started and effective. And then once you've had some experience under your belt as a CI, then that level 2 course helps you to add a little bit more structure now that you can anticipate where your problems might come in.
Yeah, and Laurie, one follow-up to that, because only going through the level 1 myself in the past, what I really did like about it was how there was a lot of role-playing with certain situations, and that I found extremely valuable, because that's the first thing I was thinking going through this course. I'm like, well, what if this tough situation happens? And they covered it. So I thought that was very, very valuable and helpful.
Well, and I think the beauty of that course too is, and again, just taught that one a couple months ago as well, is it just allows for so much dialogue between clinicians of different levels and experiences and clinical settings, and really delving into, well, what kind of problems have you had? How did you resolve it? And then always reflecting back to, hindsight's always 20/20. What would you do different today, knowing what you know now? What would you do different tomorrow with your student, knowing what you saw today? And the role plays, the dialogue, the discussion. There's actually a role play in there, as you well know, on conflict resolution, which none of us like, right? No one wants to have a conflict, but if you at least can have some strategies in your head ahead of time of what makes for effective, I like to call it interest-based bargaining, but conflict resolution, how can you get through that? What are some skill sets for you? I mean, all of us have that in anything that we do. So it's not even just what's going to help me with students, but what might help me be a better clinician, a better colleague, just a better life skill type thing.
I know that some of the most effective clinicals I had as a student was the ones that had what seemed like a relatively formal curriculum. So what are the recommended things to consider when a clinical instructor is creating a clinical curriculum for their student?
Well, definitely that's something I'd recommend people go to the course because it spends 2 whole days doing that. But again, in general, I think you just have to look at what is the end point. Not every student's end point is entry level. And I still, like on an integrated clinical experience, your goal is not entry level. And yet I see a lot of CIs that teach to where they want them to be at entry level versus where they're currently at and where they need to be. So the beauty of having structure is knowing that you're not skipping over really important content that's important for a student at any given level, and that you're not missing out on the experiences that are critical for that student in your site. So if they're only going to have one acute care rotation, what do they really need to have and have exposure to and get out of that experience? What's most important, and how do you make sure that that occurs? So I'm a fly by the seat of my pants kind of person, and everybody who knows me knows that about me. I have to work hard to structure things because I'm comfortable with ambiguity, but that is not how most people learn, and that's not what's comfortable for most people. And even for myself, when I'm in something that's unfamiliar, I have to go back to a more structured way of doing it and getting through it so that I make sure that I hit on every point that I need. Well, a student in a learning environment, everything is new. And that's why we can't just assume that the way we learn, because we're experienced and we can use more pattern recognition, we can fly more by the seat of our pants. That's not how a new learner learns. Everything's new and they need more structure. So I think the level 1 starts to touch on the importance of that. And the level 2 gives you the opportunity to really add that structure. So I don't know, I guess to me, teachable moments, like I said before, are great, but you really need to have some planned learning to make an experience successful.
Yeah, and Laurie, kind of going off of that, mentioning, of course, planned learning and that avenue of the curriculum, apart from what you had said earlier and kind of considering both level 1 and level 2 courses, what would you say are probably the biggest take-home messages and most important points from those 2 classes that you think all SHIs should know and be aware of?
I would say level 1, the one thing I always say is that the best gift you can give your student is the gift of time, the time to reflect, the time to internalize. And I don't mean just, hey, go think about that, but to really say, okay, I want you to reflect on what you just saw. Why do you think I did what I did? I want you now to go think of 2 treatment ideas that this patient would benefit from, and 2 treatment ideas that you might do if the patient's regressed, or something that's structured. Like, now that you've seen what we've done with this patient in physical therapy, I'm going to have you follow them through OT and speech, and I want you to look at what do they do and why do they do it and how does that fit in with the bigger picture. So time to think and internalize. Students don't learn just from doing things because they may just be imitating you, that you don't know that they had a thought process around that. So to me, the level 1 take-home messages is students need to do, and they need feedback on what they're doing. And you need to question them to find out what they're thinking. You can't just assume, that they made the right decision. Great for them, but why did they make it? So really, it's giving that student the gift of time, of reflection, of asking questions, and of developing them and letting them get a sense of who they are and how they practice, and helping them along that way. The level 2 course is, to me, the take-home messages begin with the end in mind. And we talk about that all the time. Know what you want and have a plan to get there. And if you look at the level 2 really focuses on what could you write for goals within professionalism? What about all the aspects of the patient-client management model where students get stuck? Like, for example, they might know all the tests to do, tests and measures and examination, but they don't know what always to do with all those tests and measures. Sometimes they get too much and then they don't know what to do with that. Or they get stuck. We all know that students struggle in the prognosis piece because they don't have the experience to say, well, based on what I'm seeing, here's where I think you're going to be or how long it's going to take. So could we structure something to help them within the prognosis area? It also looks at advocacy, which I think is critical. There's a piece in there on the interprofessional, So it looks at opportunities, again, to think about where students should be at in your experience and how to get them there.
What do you guys base the content in the level 2 course off of? Like, what do you guys use specific sources, specific evidence to develop that curriculum?
Well, there's a lot of evidence in clinical reasoning. So there's a whole section on clinical reasoning and the different models of clinical reasoning that are out there and how you might facilitate that for students at different levels. There's multiple, it looks at and incorporates the ICF model and how you might focus on the student's ability to recognize personal and environmental factors that we certainly know impact the overall patient more so than anything else, along with comorbidities. We utilize the patient client management model and a lot of the APTA resources. In fact, we do a whole section on, going through PT Now and the different sections and academies within the APTA and how they can be resources. We look at interprofessional resources like the interprofessional educational competencies. We have a section where they go through those competencies and how they impact, and we do a little demo on looking at the different resources around interprofessional practice. So there's different resources that are woven throughout the entire workshop that we try to help them realize that getting evidence is not as challenging as you might think if you're an APTA member, because you can utilize PT Now, which is an amazing resource. And then just all the other resources that are out there for them. And we give them time to play with that so they can actually get a feel for, wow, this is pretty cool. And we could utilize this, and how this actually puts us in touch with research that validates. And if we want to dive a little more deeper into that content area. So for those of you out there listening who aren't aware, PT Now for every, the Rehab Reference Center to me is the most amazing thing that you can go to, and you can get articles and links to tests and test formats and videos and reliability studies. So, I think we just try to weave that into the course around the whole clinical reasoning process and different teaching strategies, like borrowed from medicine, the 1-minute CI, which is not a 1-minute interaction, but how long the CI talks versus the student. And that's modeled in the course. So we pull from a lot of different professions and a lot of different evidence that's out there to put that curriculum together and to look at what are your resources for teaching.
Yeah, and it'll be interesting to kind of see how that continues to develop, especially as you had mentioned with the ELP, looking more into clinical education. So seeing what comes up from that. I know, of course, there's been other couple things too, like the Journal of Clinical Education and Physical Therapy relatively coming out. So it'll be interesting as we get more data on the clinical education part of it, how that potentially can change things. So I'm excited for that.
Yes.
But Laurie, one quick follow-up to the classes here a little bit, because recognizing that I know the level one, these have both been around for a little bit of time here, with, of course, level 2 being more recent. But as you know now, what has been the feedback been from stakeholders in regarding both the level 1 and the level 2 credentialed clinical instructor programs?
Well, I've heard nothing but positive feedback, which, I'm maybe just a little bit biased, but when you look at the course evals, they've been fantastic. And I think what I like to see is when a course eval says, I really, feel like I can do this, and this makes me excited about wanting to be a clinical instructor. And I came in here not sure, but now I feel confident. But I go back to an experience I had many years ago with a gentleman we were kind of sitting in a horseshoe, and I had about 15 clinicians, and he was kind of sitting in the corner, and his chair was faced away from the inner circle part. And he was kind of tapping on the table as he was sitting there. And as we were going around doing intros, he said, well, I'm the manager, and I'm just here to hear what they're hearing. And I'm like, okay. But I tell you, by the middle to end of the first morning of the first day, he had turned his chair around and was engaging in the conversation. And afterwards, he said to me, this was amazing. I learned just as much about how to be a manager, how to manage people, and how to work with my patients as I think my clinical instructors got with working with students. And I was like, that is pretty cool. So I would say that the people love it, and they say that it helps them in so many different ways to give them strategies just to work in the healthcare setting, not even just with students. The student part obviously is the big bonus, but so I've heard nothing but positive feedback. And the level 2, we always got positive feedback with the advanced, but it was a little heavy, and only PTs could participate. The current level 2, it's both PT and PTAs. So we've had some really, really good feedback. Of course, I just taught 2 weeks ago. People were leaving going, "Oh, this was great. I can't wait to go and start this. I can't wait to." And I tell them, your curriculum is an evolving document. Put it on your computer, because it's not. You're going to always be looking at how to make it better, or how to have drop down boxes for the student at this level versus that level, the student struggling with this versus the student who's excelling. So I think the sky's the limit, and they recognize that when they're leaving, and are really grateful for how to take it a step further and how to make it more efficient.
I definitely agree that I can understand why that manager learned a lot about how to manage people with that course, because when you are mentoring a student, you're trying to help them develop into a better clinician, and that's what a manager is there for, to help you develop as a professional. So, it sounds like there's a lot of great things that have come out of these courses, but, what are some of the limitations of the CCIPs, and when it comes to reducing unwarranted variation in clinical instruction? What are some of those limitations?
Well, as always, some of the biggest limitations are, now you go back to reality in your clinical sites, and how much time do you have for clinical education? Do your productivity expectations soften a little bit, especially early on? How much buy-in do you have from the people around you? Do you have support of the people around you to maybe help you out, to take a couple of patients to unweight you early on, so that you can really do a good orientation and talk through of objectives? Do you have other staff that are willing to take that student to show them different and interdisciplinary, not just within PT or PTA, but that to work with an OT or a speech language path or social worker or rec therapist or PA or whoever you have in your clinic with you. But I think the most important thing is, do you have administrative support? And clinical education is probably the most effective and efficient recruiting tool. You've got that person in front of you. You've trained them. You know what they look like. You know what they can do. So it's an intangible benefit. And it's not like you're going to hire everybody. You may not have an opening, but it helps you as a clinician to be a better teacher and to reflect on why you do what you do. So it's not, sometimes it just challenges, why do I do that? That's a good question. Like, I do this because. So I think there's so many intangible benefits that the clinical site gets. And I think our clinical instructors get that, but they may or may not always have the administrative time and support that they need, and how clinical education is administered at individual sites is always going to vary. So I think the more people we can get through these workshops, the more they can go back and advocate for their clinical education program, and then perhaps we can start to see some more consistency. But I also think that's, not that that's our only role, but as the director of clinical education, I really try to establish relationships and work with our clinical sites. I'm going to be going next week to a site in Green Bay just to talk a little bit more in depth about learning styles, because their CIs were at our level 1 course, where we talk about learning styles as one of the things to consider with helping your students, but they want more in depth. So I'm going to go up there and spend a little bit more time talking in depth about learning styles. So I think that being willing as an academic program to also help facilitate our clinical sites through in-servicing and helping give them some information on how to be more efficient, because that's really what they need to sell to their administration. In Wisconsin, we created a challenges and benefits that we did with a clinical focus group on what are the benefits and challenges of clinical education for the student, the clinical instructor, the site coordinator, as well as the site. And we utilize that for our clinicians to be able to take to their administration and say, here's the challenges, but here's the benefits of having a clinical education program. So, yeah, I guess the main question is, how do you assure that, that this gets integrated? And the answer is, well, right now it's a crapshoot. And we just hope that by continuing to educate that we will continue to help our clinical sites be more effective and more efficient and have resources and evidence to go back to support why they're doing what they're doing. And certainly the support of the academic institutions to help them along the way as they need it. So I hope that answers your question.
What about, what advice do you maybe have to some clinical instructors who are taking students from multiple schools? Because, one thing that we have talked about on this podcast before is that there is a lack of standardization in DPT education. It can vary program to program. So what is your advice to clinical instructors who are taking students from multiple sites and maybe they have different curriculums or focus?
Yeah, that's a great question, Stephanie. I think that is a big challenge. And I know it's something that it may not be an explicit part of the workshops, but it is something that I always address when I teach them. And certainly it's something I always do a thing at the start that, well, what do you want to get out of this? And I write it down on a board that I put in the room to make sure that it gets addressed and where it needs to be. And one of them is always, how do I teach at different levels and how do I know? And again, I think what we do is we send out our curriculum and we have our students bring it with. But my advice to the CI would be, know what level your student is at. Be familiar with the curriculum, know what the expectations are for that clinical experience, and then just keep an open mind that not every student is going to look the same, even from the same program, because they all come with different backgrounds, different experiences, different skill sets, and some will progress more quickly than others, and some will progress more quickly in certain areas than others. They're all different. But the foundation starts with know what their academic curriculum is and know where they're at in that curriculum, and then know what the expectation is. And, maybe as a new CI, start out with doing a little bit more consistently one or two programs that, like a lot of times our own students will take a student because they know the curriculum. And then once they get more comfortable as a CI, then they start branching out and taking other students. But, you can start with just one or two programs if that helps you get your process down and understanding, and maybe start with certain levels so that you know what to expect there, and then kind of, again, branch out. So I know that as an academic, as a DCE, though, we're like, we just need people to take students, but I don't want people just to take students to take them. I want our students to have the best experiences they can have. And I think all clinical instructors want to do that. It's just they may not always have all the tools and the knowledge and the ability and the resources to do that. So I guess my take-home message to the CI would be, start with what you're comfortable with, be knowledgeable about that student. Don't be afraid to ever reach out to the academic institution if you have questions. I'd rather hear a question in the first couple of days than later on when it's harder to address, and know that you've got us here for you to help you through that process.
Yeah, no, that's a really, really good point, Laurie. And, I want to go back a little bit to the feedback and such, because thinking, at least for myself, thinking about the level 1 and level 2s, I know sometimes for some people, something I've heard from others as well is regarding being able to go to the live course and being able to have that coordinate on a time when they're off and such to be able to make a live event. So I know access has been something that's been brought up, but I also know that sometimes mentorship through that has also been something that's kind of been discussed. And interestingly enough, a few months ago, we had someone who brought up the idea that, well, I guess she didn't come up with it, but she said it's been talked about, at least, about their making a continuing competence or continuing like certification thing for CIs on top of what already exists. What are your thoughts on this? And do you think that is a potential solution?
Well, I think it's certainly a viable option. One of the things that the clinical education board, the Credentialed board that's always looking at revising and workshops, is getting closer to an online format for the level 1 course. And I think that would be very helpful. Now, I know that there's so much rich discussion that happens in a face-to-face, but not everybody has the ability to get away for 2 whole days. And you can't win, because if you do it on a weekend, they don't get any comp time. But if you do it during the week, it's hard to get away because of patient care. So if we could have an online format to be able to administrate that program, I think more clinicians would jump in and do it. And I look at that and I say, you get 15 contact hours for this course, 2 of them in legal. So if your state like mine requires legal ethical, you've got 2 hours of a section on legal that you can also count. So you get a lot of bang for your buck as far as your clinical education time. But bottom line is one of the things that came out of the ClinEd strategy work group was having a repository of clinical education resources. And that's certainly something that we are addressing and looking at. Where can we have like a one-stop resources where you can go to access as a clinical educator, so that if you want this information, you can go and get some more information about it. So I think that would be fantastic. If I had my ideal world, what I would like to see APTA do, and I've talked about this, and I know the logistics are challenging, but within the Academy of Physical Therapy Education, we have a clinical education special interest group. And there may be other sections and academies that have a special interest group with ClinEd, but what I would like to see is an APTA clinical education special interest group that transcends all practice settings, that you don't have to be a member of this section, because a lot of people don't, if they're going to spend their money, they want to spend their money on what they perceive to be a content area like ortho or neuro or peds or wounds or whatever, versus joining the Academy for Physical Therapy Education, where the ClinEd SIG is currently embedded. So I'd like to see that as a resource where we just have a clinical education SIG that transcends all of our practice settings, so that we can talk about all of our challenges and have a bigger repository of information. I think that would be a great resource. And I think if you had a credential, like kind of like a clinical specialty, how about the clinical educator specialty as a recognition for their expertise in teaching and clinical education. So I think all of those would be, really great ideas for us to take a look at and see if we can do that, because more and more people just don't have the time, and we need to have resources. But I think we also need to recognize the people that are doing good work, and let them know that this is our curriculum. These are our future professionals. I mean, this is something that we need to put that value on, to continue to develop and provide resources for.
Well, no, I think that's a really interesting point. Is that's actually something that I have not quite heard to that level. So I always love it when I hear something new. And we've heard from a few others on this podcast that there is a concern that about the ability of clinical faculty to accurately assess student performance and intervene appropriately in clinical education. From your perspective, how do you think that this should best be addressed?
Well, I think it's kind of a 2-pronged problem, probably multi-pronged problem, but let's just start with like the 2 things that pop into my head immediately is, first and foremost, time to really see how that student is working and integrating. I'm a huge sports fanatic. I played Division I softball, and I love sports. I've mentored, I've coached, I've done all of this, stuff. And I really think that if you watch that student interact, like you're watching a basketball game, like you think about all your knowledge and how you know how to play the game. And it's so easy to sit there especially now during March Madness, and watching all these games and saying, oh, they should have done this, or didn't they see that guy open down there? Or why didn't they look to their wing? It's easy when you're on the outside looking in to see where the team breaks down. And yet, how often does that happen in clinical education, where we take the time to really assess, to see where that student is either excelling or breaking down? And again, I don't mean breaking down in a bad way. The reason they're in the clinic is to learn and to develop their skill set in all the domains of learning. And we need to recognize that we have to help them in all the domains, not just what they know and what they can do, but How are they communicating with the patient? How are they communicating with the team? Are they confident? Are they overconfident? Are they underconfident? We need to be able to provide feedback in all of those different realms. And in order to do that, we need time. We need time to watch, to observe, and to provide that. So that's one side of it. But the other side is the comfort level of providing feedback. And I think we all know that where students struggle, they're going to struggle more in the affective domain, the heart, the values, the behaviors, the communication, the interpersonal skills. And we feel less comfortable providing feedback in that area. And I think that's one thing that the workshops really do a good job of, is helping CIs develop their skill set in assessing the affective domain and giving tools like the taxonomies, the professional behaviors, other things to help them have words around how do you provide that feedback, and how do you do it honestly, and understand that you can't make changes if you don't know what it is that you need to change. And that you don't just say, oh, it would be nice if you, because that just means it would be nice. It doesn't mean you need to. So being more direct and being more, keeping it fact-based and how that behavior is impacting the patient interaction versus making it feel like a personal attack are all very important skill sets to develop as a clinical instructor. Again, I incorporate that in the curriculum at Marquette. So my students learn how to give good feedback because I think that's so important. But that's not always part of a curriculum. So they may learn that skill out in the clinical setting. So I think we really need to help CIs understand how to provide good feedback, which actually feedback is assessment. And then we also need to give, there needs to be time for them to be able to see how that student is interacting and what they're doing and how they're doing it, so that they can then give that good feedback and assessment.
Yeah, I think that that's really important. I mean, not only for the clinical instructor to obviously give feedback to the students so that they can develop into a great clinician, but also for the student to give good feedback and constructive feedback to the clinical instructor so that they can continue to enhance their ability to teach. Do you see any changes being made, or what changes are currently being made to the CCIP classes?
Well, first off, I'd like to just, on something you said there, Stephanie, I think is really important, and that is feedback being a two-way street. And in the level 1 workshop, we look at various tools from both Emory's work, the Cleveland Clinic work, that self-assessment for the clinical instructor. However, we also say this would be a good way to, to give to your student and say, how am I doing? Like, if I'm going to say, I want your feedback, then I've got to listen to what you're going to say to me. And I've got to model that ability to provide and accept feedback. And some of these tools out there can help us think about what is good teaching. APTA has a great tool on guidelines for the clinical instructor, the site and the facility, as a self-reflection tool of where am I at currently? But I always say, give that to your student, have them fill it out too, and get some feedback. So I think that point of being a two-way street is really important. As far as improvements, the board for the credentialed instructors is always working on what to update and how to make it better, how to make the flow better. They did an update on the level 1 course a few years back, kind of reordered content, added content, took some things out, and they're currently looking at that again, especially with this online format. Certainly did a whole revise of the advanced, which is now the level 2, to such that it's just much more effective, and I think much more relevant and helpful to the clinical instructor and the site. So I think it's an ongoing process, just like clinical care. I mean, patient care is ongoing. We have to always consider the evidence. We have to always look at what's in front of us and what could we do differently, what could we do better, and that's one area I think the board, it rotates off members, and there's been some members that have been on there for quite a while, but they're very experienced people in clinical education and in curriculum around it. And they're always, it's an ongoing process of looking at what we could do better. There's a discussion board in the communities on APTA website for credentialed instructors to be able to go to get ideas on teaching strategies and what are you doing and how is that working and what might I try? And so even within our trainers, we're always looking to each other to get ideas on how to do things differently, how to do things better, how to deliver the content in a way that's going to be effective, which is obviously what we want to do. So I think it's an ongoing process, and it's certainly been a very effective board that has worked very hard to make sure that these workshops are relevant and current.
No, I'm definitely sure on that. And, Laurie, I want to go back to that one early piece that Steph brought up about feedback being a two-way street. One thing that I know has come up, at least I've experienced, I've heard from other students as well, is kind of sometimes the hesitation for students to write out true feedback out of fear of retaliation from either the experience or with the CPI. Has that topic been discussed, and what are your thoughts on that?
Well, from the clinical instructor perspective, we address that in the level 1 especially, and also in the level 2, because we're always looking at, again, you have to be willing to accept feedback. And in both courses, we talk about what is good feedback and how do you provide it. So I always talk about the sandwich cookie, where you start with something that they're doing well and then transition to what they need to work on. So for example, a student does a manual muscle test and the patient has to constantly change positions. However, they have the right hand placements and they're getting the appropriate muscle grade. I might say to that student, you were able to effectively obtain information from your patient. You had your hands in the right spot. You had the right muscle grade. However, your patient had to keep changing positions because your sequencing wasn't efficient. And by the time you were done, the patient was really tired. So you're doing a good job of actually obtaining your information. Now you need to work on your sequencing. That sounds like a lot of information. But what it does is it really diagnoses what the problem is. I didn't just say to that student, you need to work on your manual muscle testing. Well, that's not helpful because, well, all of it, part of it, what part of it? So we always try to help the clinical instructor provide the feedback that's going to be helpful, that's diagnostic and specific, and it's timely, and the student knows exactly what they need to do to improve. So we do that in both the level 1, and then we revisit it again in the level 2 about how important that feedback is. And no news is not good news, and no student doesn't want just positive feedback, but they also don't want feedback that's negative and not phrased in a way that they can do something with it and grow. So I think how you phrase feedback is critical, and definitely the response you get to it is in direct relationship to how it's delivered. So we really want to work on the delivery. But I also would like to challenge any academicians out there listening to this podcast that's a skill you really need to start developing in the academic programs. It's because if you want your student to also give good feedback, they also need to learn how to give good feedback. And emotions can get the best of students sometimes in the clinical setting when they're frustrated and everything's new and they don't feel like they're doing well and they don't feel like they're getting the guidance they need. And sometimes the information that comes back to the CI cannot be perceived, can be defensive or be perceived as negative. And I just really think it's critical to talk about giving good, effective feedback, because you also have to make your learning needs known. I mean, you can't wait for someone to teach you. You have to know what you need to know what you don't know, and be willing to go after that and be willing to ask for that feedback. So I might spend a couple nights a week with a student talking about how do you make your learning needs known? How are you going to ask for the feedback and let them practice with me if they're struggling because their CI doesn't give them feedback? So we talk about it, and then they try it, and then I call them and say, well, how did it go? And we continue to mentor and help them, because they're not just there to be facilitated. They have to take an active role. So I think students need to learn how to give good feedback, make their learning needs known, but it has to start in the academic setting. They don't just go out in the clinic and voila, they can give good feedback to their CI or ask for feedback. They need to be mentored with that as well.
Yeah, no, that's a really, really good point, Laurie, and I'm glad that you brought that up. It's interesting. I want to switch gears to ask one question on your role as a DCE. And of course, being involved with the ELP, what have you found are some ways that really help incentivize CI development, given all the responsibilities and the barriers that CIs face these days?
Yeah, I think the majority of the CIs, if you ask them, why do you do this? First and foremost, they feel it's their professional responsibility. And then secondly, they talk about how they get energized because they're excited to see that learner develop, but they also feel like they are learning as much. So I always say that the students that you get now, both PT and PTA, come to you with more knowledge than we ever had when we started. At least I know for myself in a bachelor's program. But what we have as a CI that they don't have is how to take all that knowledge and apply it. And so you need to really understand that this is a two-way street. You're going to learn about the current evidence. You're going to learn about updated techniques, but you're going to teach them how to use that. And you need to model professional humility that, hey, I've never heard of that before. Why don't you tell me about it? Why don't you show me how to do that? But by the same token, you're going to help them understand the patient aspect, the patient value, the craft knowledge of the evidence-based. You look at evidence-based practice, it's not just the evidence, it's the clinician's experience and expertise as well as what the patient wants and values. And that's what we bring to the table in that relationship. And so if you look at it as a relationship where you're mutually beneficial, that can incentivize. I think personally, I try to incentivize clinical instructors by offering to come and do little workshops. I did one this past weekend for a PTA program, going next week to a site. So being willing to get out there and if you've got this audience that's captive and wants the information, you've got to jump on that and look at that opportunity to get them excited and give them some tools and know that you're there as a resource for them. I guess I've been blessed at Marquette in that our leadership has always been supportive. Our dean and our program directors have always been supportive of us getting out and educating and taking every opportunity that we can to help our clinical sites, because it makes everybody's clinical education better, not just our students, but all students that are out there in the clinical setting. So we try to give, and I think a lot of academic programs do that, where they give like free CE credits or discounted CE credits, access to your libraries. I mean, we try to do what we can to incentivize CIs, but I think the main incentive comes from internally, is their desire to want to be a clinical instructor. And we just need to feed that with, we're here to help you, we're here to support you. I think it helps when you address the professionalism aspects in the academic curriculum, and when you talk about the feedback, when you develop self-assessment and reflection skills, that makes an easier student once they get to the clinic. So I think having a student who's prepared in those affective skills is helpful, but also being that person who says, I'm here to help you. I'm not, the student's having a problem. I believe you. All right, so what can I do to help you with that student, rather than, oh, that's that. They were fine on their last clinical experience. I'm sure it's just you. And I've had sites tell me that, where they've been basically told they're the ones with the problem. And it's like, why would I send my student out to you and ask you to invest all this time if I'm not going to support what you're telling me? So I think that incentivizes CIs to say, hey, you know what? I had a problem student, but I had help. And it actually turned out it was successful, and I learned a lot from that experience. So I think there's a lot of ways that we can incentivize that doesn't have to be monetary, since we don't have the money in our programs to do that. But we do have staff, and we do have time, limited, but we make time, right, to be able to help our sites out as best we can.
Yeah. And, one last thing on the clinical instructor piece, because I know there's always a balance between doing the work as a clinical instructor, but also having to document about it and submit all the things that are required. Where do you feel that pendulum swings now? Like, are we kind of at a good way in between? Are we kind of skewed? That's something I've heard from CIs as well, is they kind of feel kind of overwhelmed and frustrated by that. And again, not all of them, but it's just something I've heard.
Yeah. Well, the bottom line is the D word documentation doesn't make anybody happy on either the patient side or the CI side. So And I get it when you're busy, and not all sites give you time to work on the CPI or whatever tool you're using. Again, I think the level 1 and level 2, the level 1 helps to give you ideas on how to be more efficient with your assessment. We don't specifically address a specific tool, but I think CIs need, if you do the weekly planning forms, you have a paper trail of how things have been progressing throughout, so that you're not sitting down in front of a blank slate saying, what do I remember from week 1 that I'm going to write here? I also encourage students to, and I'm going to use the CPI only because that's what we use, is go in from day 1 and make comments. I mean, make little notes to yourself. You can always change it. Even though you save it for that day, you don't save the whole thing until the very, very end. So you can go in and start making comments, start, making note of things that you've seen, both constructive as well as things the student needs to work on, so that you don't have to do it all at one sitting. And then that way you can be more efficient with your paperwork. I've also talked to CIs about create yourself a template in a Word document that says student is carrying X% of the caseload, X is simple, X% complex, so that all you have to do is fill in the blank and then provide examples to support it, and you can copy and paste. So, again, that's one of those benefits of trying to work with sites on how can you be more efficient. I think the level 2 helps them because of the structure and knowing that the students are getting these experiences because you have it already planned and structured helps them with the paperwork. But I'm not going to lie. I'm not going to say that, the paperwork's, nah, don't worry about that, because good assessment takes time, and the student doesn't remember everything you told them. So all they have at the end is what you wrote. And God bless the CIs that really take their time to do really good reflective feedback, because that's really helpful for the students, but the students should be doing it too. Like, a student shouldn't get away with, doing these behaviors. They should be doing good reflective summary as well as formative, the formative assessment on themselves. So how do you make it more efficient? I think the best thing you can do is just do the weekly planning forms, have your paper trail, write in as you go at whatever assessment tool you're using, so that you're keeping up rather than catching up at midterm and final.
No, that's a really good point, because I just had to bring that up because that's something I hear.
That's okay. It's real.
I know. I hear that all the time. So, Laurie, I really like the insight that we've gone through, because I feel like I've learned a lot more about this program and clinical education, learning from your perspective, of course, with all that you've been involved. So I really appreciate that, and I really appreciate your time. But of course, we have to finish off with our big finale question that we ask everyone. So if you want to say something that you had said beforehand and further reiterate it, that's fine. Or if you'd like to bring up something totally different within the realm of education, that's equally fine as well. So whatever you feel. So the question is, if you could change one aspect of healthcare education, physical therapy or other healthcare provider related, which aspect would you change, and how would you change it?
In my ideal world, every single curriculum would really explicitly have a pathway for developing the professional affective aspects of care. I think we all tick our boxes for the different, science-based and topic-based things that we need to cover, but I don't know that we necessarily develop our students as professionals, that we really truly look at how important it is in the academic setting to address communication and interpersonal skills, and how students receive feedback, and how they manage stress, and their clinical reasoning processes, and their ability to take responsibility for what they're doing. I just think that's the most important gift that we can give a clinic, as a student who has self-reflection skills already, and that student is accurate. Now, again, I do that in my curriculum. Do all my students develop that skill while they are students? No. It's a process, just like anything else. But at least they have a starting point, and it's not just something that's, okay, professional behaviors are important, you need to dress appropriately. Well, okay, that's important, but that's not all what professional behaviors are. So I think if we had a better explicit way of looking at professionalism in our curriculums that address both interprofessional respect, professional humility, and that we really have mechanisms for assessing that. Because people will say you either come with it or you don't. I don't believe that. And some people will say, well, you you can't teach that. I don't believe that either, because I think you teach it through assessment. You teach it through modeling, you teach it through teaching it, and then you teach it through assessing it. And if you're getting feedback on it, you're going to make the change, because if you don't, you won't be successful. And it's not the clinic's job to do that. The clinic's job is to refine it in the context of patient care. So I guess that would be in my ideal world, all of our curriculums in all of healthcare education would really take the time to develop the professionalism aspect. And I think if we did that, the world would be a better place. The bottom line is patients want to know you care before they care what you know.
Yep.
And you can, if you can establish rapport, you're going to go a lot further, and that patient's going to want to work with you more so than if you don't have those skills to develop that rapport. You can know everything in the whole world about everything, but if you can't relate what you're doing, because to me, the biggest problem in health education, or just in healthcare in general, is the whole issue of people don't understand that, like health literacy. It's not just about whether you can read, it's what you understand. And so many of you can't just fix it by throwing money at it. You have to educate. And education is the key to success and patients' understanding. And that all goes into that, recognizing that as a professional, is that it's that patient-centered care. I mean, I could do a whole podcast on informed consent and patient-centered care, but it's just so critical of a skill to have as a new graduate, because you don't have to know everything. You never will. And if you can recognize that, the main thing that's going to be most important in my relationship is my therapeutic alliance with my patient. And if I can develop that, then the rest can come. I can always go and ask other people questions. I can always help this patient and get the knowledge. But if I don't have the relationship, none of that else is going to happen. So to me, that's why that's my answer.
No, I couldn't agree more. I think that's a very valid point. Well, Laurie, where can people follow up? Should they have a question about kind of what we've talked about, or where can they kind of find out more information about the courses as well? Because I know early we mentioned the ELP, but what would you recommend that people kind of look into if they want to learn more or ask a question?
Yeah, well, APTA, on the APTA website under the education, you can get to the links that tell you descriptions about each of the courses, level 1 and level 2. There's also links there about who are trainers. So if you are thinking about hosting a course in your area, you can go in and look and see if there's a trainer in your area. If there's not, you can reach out. Like I've gone all over the country to do these workshops, but you can reach out to different people, may start locally. And also reach out to your academic program. So I just did the level 1 for a PTA program in the area, but the clinicians are PTs and PTAs that come. So your local programs will know about when they're going to have the workshops, as well as like who can come and what kind of support they can give you, and even your state professional organizations. So we publish every time our state publishes their PT Connections, there's always an update on when the workshops are going to be and where they're going to be. So there's a lot of different places that you can get the information, but if you're not sure, start by contacting whatever academic programs you affiliate with, and then utilize the APTA website. I don't think you have to be a member to get to the information, although I always strongly advocate for membership, but you certainly can at least get the information about the workshops and the trainers if you need that.
Perfect. Well, again, Laurie, thanks so much for your time, insight, your service, and all that you do. It's been a pleasure having you on again.
Well, thank you for having me, and thank you for your emphasis and your passion for educating our members and non-members on how important clinical education is. I really appreciate that.
No, the pleasure is all ours. We love talking about it.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.